Pharmacy 104, Chapter 6, Treatment of Depression. Objectives for Lesson 6.1 for depression. Learn the terminology associated with depression and its treatment. List and describe the functions of neurotransmitters associated with the symptoms of depression. Key terms will be found on Canvas using a Quizlet. So for an overview of the description of depression, this chapter talks about the treatment of depression. There are three primary types of depressive disorders: major depression, bipolar disorder, and dysthymia. I practiced that one about 50 times, and of course on tape, I bugger it up. Depressive disorders may be precipitated by hormonal changes such as in premenstrual syndrome, during pregnancy, or postpartum, from substance abuse such as alcohol or other depressant drugs, illnesses such as Parkinson's disease, heart attack, thyroid dysfunction, also things like chronic pain, cancer, other things can bring on depression. Heredity can also play a role, especially in bipolar disorder. Major depression is also known as clinical depression. It's associated with persistent feelings of sadness, emptiness, hopelessness, lack of interest in activities, fatigue, being overly tired, irritability, and the patient may suffer from insomnia, unable to sleep, or hypersomnia, where all they want to do is sleep. Bipolar disorder and dysthymia. Bipolar disorder was formerly known as manic depressive disorder, and it's associated with sudden swing of mood between depression and periods of mania. So mania is like a hyperactivity component. Patients have racing thoughts, their inability to sleep, they're easily distracted, they have increased goal-oriented directed behavior. It's like they can accomplish a whole lot very, very quickly. Dysthymia produces symptoms that are similar to major depression, however, the symptoms are less severe. So let's talk about the neurochemistry of depression. So there's a biogenic amine theory, and what this is clinical depression results from a decrease in stimulating hormones. Those are monoamine neurotransmitters in the brain, like dopamine, serotonin, and norepinephrine. So GABA may also be involved. There isn't a lot of information on this, so the chapter touches on it, but it doesn't really have any depth in that. Now, bipolar affective disorder, or that mania component, is believed to be associated with increased levels of those monoamine neurotransmitters. They're excitatory, so during the manic phase, there's an excess, so there's an overexcitability of those neurotransmitters. So here's a picture of nerves and synapses. So in depression, we see that there is a decrease in norepinephrine, and then in mania, there's an excessive increase of norepinephrine. The role of norepinephrine in treating or in depression: decreased levels in the brain are responsible for depression, and increased levels in the periphery can cause hypertension. For serotonin, serotonin is an excitatory neurotransmitter. More than 9 of the serotonin receptors have been identified, and drugs that block those are used to treat depression. And what that is it leaves more in around to make connections. Dopamine, there are 5 types of dopamine receptors. Dopamine binding is less involved in the treatment of depression than norepinephrine and serotonin. The second part of this lesson is about the medications used to treat depression, and the objectives involved in this part of the chapter include classify medications used to treat depression, describe mechanism of action for each of the drugs used to treat depression, identify significant drug look-alike and sound-alike issues, and identify warning labels and precautionary messages associated with the medication used to treat depression. So drugs used to treat depression, how they produce their effect is by either inhibiting the reuptake of specific monoamine neurotransmitters or blocking the breakdown. So if we inhibit the reuptake, so here we have a photo picture of a neuron terminal end, and norepinephrine is the neurotransmitter that's coming across to connect with our receptor sites on the effector organ, so either alpha or beta adrenergic receptors. So it comes over, and when the green hits, it means that it stimulates the receptor. So what can happen is the norepinephrine, when it's done, it can be recycled, brought back into the nerve ending where it can be recycled and reused again, and that's called reuptake, or it goes out into the synapse where chemicals will start to break it down. So monoamine oxidase can break it down, or the catechol O methyltransferase, or COMT, can break it down. So we're either going to inhibit the reuptake or we're going to block these chemicals that would break down those monoamines. The end result is going to be that there's going to be additional or extra norepinephrine that's around. So the more that's around, the more receptors it can connect with, the more happy hits we can get. So that's the benefit of using these drugs to treat depression. Similar with the serotonin reuptake inhibitors. They're going to inhibit the reuptake of serotonin. So the first group we're going to talk about are tricyclic antidepressants, which are commonly known as TCAs. This is the oldest group of antidepressant medications. All of the TCAs have a 3-ring chemical structure, and that's illustrated in your textbook. They all have similar effects and therefore similar side effects. Now there are what we call 2 generations. There's some older TCAs and some newer TCAs, and I'll talk a little bit more about that in just a minute. Now, tricyclics are used in the treatment of depression, but they also have some additional uses, including obsessive compulsive disorder, which was talked about in the last chapter, and then enuresis. So enuresis is bedwetting, also known as nocturia. So here is the mechanism of action for a TCA. So this is illustrated in your textbook as well. So how TCAs work, they're non-specific blockade of the reuptake of monoamine transmitters. So the monoamine transmitters include your norepinephrine and your serotonin. So these are monoamines. So it's going to stop or block the reuptake. So here we have those blockades. Whoops, go back. Oh. So these are our receptor blockers. And here we are blockading the reuptake piece. So TCAs, don't let them be taken back up. It also will block the access for the histamine. So we see that that H would fit right down in there, and also block the other neurotransmitters, the cholinergic and muscarinic receptors. So these are blocked. So the only ones left available in this competitive environment is the serotonin, which can come in here, or the norepinephrine, which can come in here. So this is our Ne, and this is our 5-HT. So the block of the reuptake of the norepinephrine and the serotonin in the presynaptic neuron and the postsynaptic receptors, the longer those neurotransmitters are in that cleft, the more chances they have for those happy hits into those receptors. The TCAs keep the monoamine transmitters available for binding for longer periods of time, thereby increasing the opportunity for those binding receptors. So just like I said, it leaves them there and it allows for more happy hits. All right, the side effects with TCAs, now they all have similar structures and therefore they all have similar adverse actions. So dry mouth, urinary retention and constipation, and blurred vision. Now these side effects are also known as anticholinergic side effects. So if we go back to the previous slide, we see that we are blocking those cholinergic receptors. So by blocking those, we have anticholinergic side effects. So there are a set of side effects that are pretty consistent, and I'll mention those many, many times throughout the entire course of pharmacology. So when I say anticholinergic, you want to think dry mouth, urinary retention, constipation, and blurred vision. Okay, here's a little note. You should write that down. It's important to remember. Additional side effects with TCAs include hypotension and arrhythmia. They do have some drowsiness to them, so they can cause some sedation. That histamine blockade, like an antihistamine like Benadryl, can make you sleepy. Well, because we have that histamine blockade, here we've got that histamine blockade, it can cause that kind of effect. So sedation, and also it can cause weight gain and hypotension. The blockade, so sleepiness, take at night. All right. So the warning labels. So those were the side effects. So if they make you drowsy, well, or sleepy, cause sedation, we want to tell the patient that it could make them drowsy. And of course, alcohol could make that effect even more intense. And because they make you drowsy, they could impair your ability to drive. Patients should not discontinue TCAs without supervision by their physician. Also, TCAs cause what we call photosensitivity. So photosensitivity can cause hypersensitivity, rashes, and intolerance to heat when of prolonged exposure to sunlight. And also something unique to the TCAs is they make discolor urine and cause them to be a blue-green color. So it's important that your patients are aware of that. We don't want them freaking out when they pee blue. All right, so your TCAs. Let's talk about the drugs. Before we do, let's talk about drug stems. So like I just said, there are two different groups or generations of tricyclic antidepressants. We have the older tricyclic antidepressants and the newer ones. The older ones have a drug stem of triptyline, and the newer ones have a drug stem of mipramine. All right, so your TCAs. Amitriptyline, which is Elavil, and I have a photo of a label and the different strengths of Elavil. Clomipramine, so that's one of the newer ones that ends in mipramine. That's an Afrinil. That was in the previous chapter. Desmip Desipramine, which is norpramine, and doxepin, which is Sinequin. So doxepin is one of those, it doesn't fit with the triptylins or the mipramines. There's also imipramine, which is tofranil, nortriptylin, which is Aventil or Pamelor, protriptylin, which is Vivactyl, and trimipramine, which is Sermontal. Now, another little note for you on the imipramine, especially, imipramine is one of the drugs that's used for anuria, for nocturia, for bedwetting. And it's approved for children as young as 6 years old to treat bedwetting. All right, now our sound-alike lookalikes. So clomipramine could sound like chlorpromazine or clomiphene. Desmipramine and imipramine and desipramine and triimipramine, they all kind of sound together similar. Then there's another drug called triamterene, which is actually a diuretic drug, and then nortriptyline and amitriptyline. So spelling, we've got to be careful. They look alike, they sound alike, and that potentially is a challenge. Now, on this list, not all of these drugs, these are not, digoxin is not, and triamterene is not. These are not your TCAs, but they're other drugs. Now, doxepin and digoxin is actually a drug used in heart failure. So we definitely don't want to get those two mixed up. Okay, your SSRIs, or your selective serotonin reuptake inhibitors, they're the most widely prescribed antidepressants. They're as effective as the TCAs, but they have less side effects. And in fact, TCAs have the potential to be cardiotoxic, that arrhythmia that I talked about. So these drugs don't have as much risk with that. The mechanism of action is they selectively block the reuptake of certain types of serotonin in the synaptic cleft. So how they work, why do I have that twice? I have no idea. I must have copied something off in my slide. So they produce a selective blockade of the reuptake of serotonin in the cleft, and it requires a specific transporter to move the serotonin across the membranes, which allows for that specificity. When the reuptake is blocked, the serotonin stays there longer, we get more happy hits, everything is great. So that's how they work. The SSRIs are well absorbed in the GI tract. They are metabolized using the cytochrome P450 enzymatic system, so that's something to be aware of. Side effects of SSRIs include nausea, anxiety, sleep disorders, sexual dysfunction, and because of that cytochrome P450 enzymatic component, they do have many drug interactions. Other things that can occur as side effects include decreased appetite and nausea, diarrhea, serotonin syndrome, and suicidal ideation. Insomnia is a common side effect of the SSRIs, so because of that, most times these are diagnosed or these are prescribed to be taken earlier in the day, not at bedtime. The warning labels associated with SSRIs may impair the ability to drive. They should not take these medications while drink alcohol while taking these medications. So generally, if someone is suffering from depression, they should not drink alcohol anyways. Alcohol is a system depressant, so they should avoid alcohol. SSRIs may cause dizziness. If it's a delayed release formulation, they should swallow it whole and not crush or chew the tablet, and they should not discontinue without the supervision of their physician. Also, doses are generally given in an increasing dose. They increase them gradually till they reach the desired effect. And then they need to be taken off them the same way. So they decrease the dose gradually. So the drugs in the SSRI group include citalopram. So like I was saying in class, be careful, this is not a PAM or a LAM, it is a PRAM. So citalopram is Celexa. Escitalopram is Lexapro. So these drugs are chemical isomers. They both contain the drug citalopram, but this one has a different chemical structure. I don't know that structure is the right configuration. That's what I should say. It's a different. It's kind of like having something and twisting it. So it's the S isomer, and it has to do with the imaging of the actual molecular structure. They have the same chemical makeup, but they're just formulated a little different because they have a little twist in them differently. So here are labels. So Celexa comes in tablets and it also comes in an oral solution, and Lexapro comes in tablets. Then we have fluoxetine, which is Prozac or Serafem. Fluvoxamine, Luvox. Paroxetine, which is Paxil. And sertraline, which is Zoloft, which I talked about in the previous chapter. Now, the thing here with Zoloft, we see that there's tablets and there are capsules. When a physician writes a prescription, they have to identify, do they want tablets or capsules? We cannot substitute without approval from the physician. You cannot substitute a tablet for a capsule or a capsule for a tablet. They will have different mechanisms. So it's very important. They are the same strengths. They come 25, 50, and 100, just like over here. So we have to identify, are we dispensing tablets or capsules? All right, more sound alike look-alike. So Celexa can sound like Zyprexa. It can also sound like Celebrex. So that could be a problem. Fluoxetine, which is Prozac, versus fluvoxamine, which is Luvox. And then we have brand names. Luvox can sound like Lavoxil, which is a drug that's used for thyroid. Or Lovenox, which is a low molecular weight heparin. So that's a blood thinner, and it's given by injection. So by paying attention to the dosing, Paxil and Taxol, we brought that up in the last chapter, that's a chemo agent. And Paxil and Plavix, and that's an antiplatelet or a blood thinner. Oops, that shouldn't have a T. That's a platelet. So these are your sound alike look like SSRIs. The next drugs we're going to talk about are monoamine oxidase inhibitors, which have the abbreviation MAOIs. MAO is the chemical, and this drug blocks that chemical that would break down the monoamines. So monoamines include the neurotransmitters norepinephrine, dopamine, and serotonin. So don't get MOA, which is mechanism of action, confused with MAO. All right, so the enzyme monoamine oxidase, or MAO, is found in terminal neurons, also in the liver and the intestine, and there are two forms. There's subtype A and there's subtype B. The monoamine oxidase inhibitors will block the action of the enzyme monoamine oxidase. So when that happens, it stops the breakdown of those monoamines in the synaptic cleft, so it leaves them available for more happy hits. So MAO type A is used in the treatment of major depression and preferentially interferes with the metabolism of norepinephrine and serotonin. But when we block it, we can also block other monoamines. Interfere with the degradation of the monoamine transmitters, also dietary amines like tyramine. When we use an MAOI, this inactivation is blocked and it results in excess amounts of norepinephrine, serotonin, and dopamine to be available for more activity and binding with those receptor sites. So the effects produced by the blockade of, there are effects produced by the blockade of the enzyme MOA. And what happens is we need to think about foods that would also increase this tyramine, which could intensify the effects of that release of those monoamines. So these foods help produce monoamines. So people who take MAOIs need to avoid certain types of foods. That includes certain types of cheeses, especially ones that are aged, blue cheese, camembert, Swiss, meats, salami, bologna, alcoholic beverages, red wine, especially Chianti, which is considered to not be a very mature type of wine, sherry, dark beers, fruits and vegetables, dried fruits, raisins, things like that, figs. So also patients should avoid stimulants like coffee, tea, and chocolate because all of those things potentially could raise blood pressure. So the foods with tyramine, here's just a little visual for you that gives you some of the lists of some of the items. Peanuts, chocolate, grapes, raisins, soy, beer, pineapple, coconut, red wine. So the thing about using MAOIs is it limits the patient's diet very much. They have to be very conscientious to what they're eating. Also, MAOIs will interfere with a lot of drugs. So we don't use MAOIs as a first line treatment. They're kind of a last resort drug. If we've tried the other drugs and they don't work, then we'll use it. Now, there are some exceptions, but generally not in depression as to when we would use an MAOI. Now, MAOIs have both could be reversible or irreversible. It takes 3 to 5 days for an MAO level to reach its normal after we stop the MAOIs. So that can take a little time. The elimination of the drug is very slow. They have very long half-lives. Recovery can take up to 2 weeks when irreversible MAOIs are administered. So the irreversibles stay there longer, and that means that they're going to have more potential for interactions with other drugs. So if somebody's on an SSRI and we're going to switch them to an MAOI or vice versa, generally the patient needs to be off either of those medications for at least 2 weeks before introducing the new medication. The side effects of the monoamine oxidase inhibitors include sedation, dry mouth, urinary retention, and constipation. So those are the anticholinergic side effects. Oops, I keep wanting to cross my T's. I guess that's not going to let me take that back out or cross my L's. That's an L, not a T. Also orthostatic hypotension. So we want to warn our patients, don't stand up too fast. It can cause impotence and it can cause a weight gain. Now, the biggest concern with the MAOIs is because of the increased levels of norepinephrine and the stimulation that can have on the heart, it can cause a hypertensive crisis. And a hypertensive crisis means their blood pressure can go up so high that it could actually be fatal. The warning labels for the MAOIs: avoid alcohol, may cause dizziness or drowsiness, and do not discontinue without medical supervision. Now, the two drugs that are sold in the United States include phenelzine, which is Nardil, and tranylcypromine, which is Parnate. Tranylcypromine. So these are the two MAOIs used to treat depression. As I stated on a previous slide, we do have some other MAOIs that have other indications, but they're not used in treating depression. For some reason, I have my food side on this one as well. So the hypertensive crisis can be fatal and is caused by drug-drug as well as drug-food interactions. So again, avoiding those foods with tyramine to help prevent the risk of the hypertensive crisis. The tyramine stimulates the release of norepinephrine, which could result in the hypertensive crisis. The patients need to be given a list of food and drinks that they need to avoid, and that list is also in your textbook, table 6.1, which is located on page 97. Okay, the next group of drugs are serotonin, norepinephrine reuptake inhibitors. Like I stated in the previous chapter, norepinephrine is the same thing as noradrenaline. That might be a good question about norepinephrine and noradrenaline being the same thing. What they do is they inhibit the reuptake of both serotonin and norepinephrine. The dual inhibition is more effective than either the serotonin or the norepinephrine by themselves. These drugs are available mostly as tablets and developed because alternatives to TCAs and MAOIs, and that they had fewer side effects. So you can see the table on page 98 for some more information about the SNRIs. Oops, did I go backwards? Oh, there we go. So now we're going to talk about the drug. Oh, I jumped ahead. So the drugs in this group include duloxetine, which is Cymbalta, desvenlafaxine, which is Pristiq, and venlafaxine, which is Effexor or Effexor ER. Now, venlafaxine inhibits the reuptake of serotonin more than it does the norepinephrine, so it focuses more on the serotonin side. And again, like I noted in chapter 5, we've got to be careful when we get an order for Effexor that we clarify. Is it Effexor tablets or is it a capsule, which would be Effexor XR, especially if it's a 75 milligram dose, since that's the same in either. If they tell us 100, well, then we know it's a tablet. If they tell us 150, well, we know it's a capsule. But if they say 75, we have to clarify, do you take a tablet or do you take a capsule? The next group are the norepinephrine dopamine inhibitors, and these are dopamine receptor inhibitors, are known as NDRIs. So this class was introduced in the 1970s, again as an alternative to the TCAs. Now, the benefit is these do not cause drowsiness. There's only one drug that we're going to talk about in this group, and it's bupropion. It's rapidly absorbed and has a weak effect on dopamine and norepinephrine reuptake. And the bupropion is taken in doses greater than 450 milligrams a day or 150 milligram dose increases the risk for seizures in people who are diagnosed with seizure disorders. So that's something to be aware of. Now, it comes in many brand names. We have Wellbutrin, which is an immediate release, and it says right here, take it 3 times daily. So this is what a Wellbutrin tablet, a 75 milligram one, would look like. Then we have Wellbutrin XL, and both the strengths for the XL are white. And then we have Wellbutrin SR. So you see where we could come into some challenges here if we're not paying attention. XL or SR. And then these come in different colors. There's 5 different strengths. Then there's another drug that's also bupropion, and that drug goes by the brand name of Zyban. Now, Zyban is specifically indicated for the treatment of smoking cessation, not for depression. The warning labels for your SNRIs and your NDRIs include that they may cause dizziness or drowsiness, they may impair the ability to drive, they should not drink alcohol. For trazodone and venlafaxine, they should take with food, and they should swallow whole any extended or sustained release formulations. They should not crush them or chew them. And again, they should not discontinue their medication without medical supervision. Additionally, sedation could be found with venlafaxine and desvenlafaxine, and duloxetine can cause muscle weakness. I'm going to jump back just for a second here, and then we're going to look at these 2 drugs again. So again, we see that venlafaxine is in both of these formulations. So this is a newer version of the drug. It's an isomer. So again, the stoichiometry, or the way that the molecule is positioned, is a little different. So these drugs do work just a little different and may have slightly different side effects and also different indications. All right, so let's jump ahead. Next, your book talks about heterocyclic antidepressants. Mirtazapine, which is Remeron, is a heterocyclic antidepressant. It increases norepinephrine and serotonin release. 2nd and 3rd generation antidepressants are as effective, but don't have the risk of cardiotoxicity and hypertension. So this fits into that group. So here's a generic bottle, and that's what the tablets look like. I've defined these a little bit more than your book did. Tetracyclic antidepressants, there's a drug called trazodone, which I've given you the warning on the previous pages. Trazodone is known as Deseril, or Oleptro is a brand name for trazodone. These are weak inhibitors of serotonin. So the trazodone, generic, these are some generic tablets, round, scored, or they could be scored. This is 150 milligrams. It could be scored, so 75 and 75, or cut this way for 3 doses of 50. Deseril, this is the brand name product, so it comes in 3 different strengths. And again, that 150 can be split into 3 50 milligram doses, or you might be able to see here slightly at the top and bottom that there's actually a score on the other side. So it could be broken into 75 milligram doses. And then Oleptro, it's actually an extended release formulation. So your sound-alike lookalikes, be careful of all your Wellbutrins. There's that whole list. Then we have the bupropion and buspirone, which we talked about in the previous chapter. So bupropion is Wellbutrin, and buspirone is Buspar, which is an anti-anxiety drug. And then Remeron, Zamiron, or Premarin. So lots of sound-alike lookalikes. Next, we're going to talk about or finish out talking about treatments with bipolar disorder. So all drugs currently indicated for the treatment of bipolar disorder have anti-manic actions. They're mood stabilizers. Lithium is the oldest of these agents, and it was introduced more than 50 years ago. Now, some medications used in treatment of seizures are also used to treat bipolar disorder. Most of the drugs in the treatment of bipolar disorder are pregnancy category D. Very important to know that. Lithium, we have the drug stem, lith, in the brand names, so that helps us identify it. Lithium is administered to reduce current symptoms of mania and depression and prevent future episodes. So lithium is given when someone has the bipolar manic component. Lithium has a long half-life and increases the longer the patient takes the lithium, so it builds up in their body. Lithium is absorbed rapidly from the GI tract and gives it a rapid onset of action, and it's basically excreted unchanged in the urine. The half-life can double over the course of a year's continuous therapy, so that's something to be aware of. Plasma lithium levels and renal function should be monitored regularly to avoid development of lithium toxicity, which can be extremely harmful to the patient. See page 99 for more information on the drugs used to treat bipolar disorder. Now, lithium, and in the book it gives Lithobid as the brand name. Here it is, and there's a 300 milligram tablet, but there is also Escalith, which comes either in a capsule for its immediate release or in the controlled release as a tablet. We also use anti-seizure drugs in treating bipolar disorder. Valproic acid, carbamazepine, and lamotrigine are used for the treatment of bipolar disorder. They're indicated as adjunct to lithium therapy, so they won't take these alone. They will take them with the lithium, and that helps produce the desired effect. Divalproix Depakote, which is the one listed in your book. So as you see here, Depakote comes in many different formulations. We have the immediate release Depakote tablets. We have an extended release Depakote. So the delayed release. We have the spantules or the sprinkles. Now, these are meant for the patient to actually open up the capsule and sprinkle the medicine on top of something like applesauce. So that capsule is meant to be open. It's not meant to be swallowed whole. So it's a little different. Similar to this, but not listed on the chart, but talked about in the paragraph and on this slide, is valproic acid. So valproic acid is Depakine in its oral capsule formulation, or Depakon in its injectable form. So Depakine comes as a capsule, and it also comes as an oral solution, and then Depakon comes as an injection. So valproate can also be given as an injection. So the thing about the valproics, they increase the availability of GABA, which is inhibitory, and since we use it in mania, it kind of calms the patient down. Now, you do need to note that the patient should take these drugs with water, not a carbonated beverage, and they should not use aspirin while they're on this medication. Carbamazepine, which is Tegretol, is another anticonvulsant that is used with bipolar disorder. So carbamazepine is the generic name, and Tegretol or Elliptal that I have on your trade and generic list are brand names for the product. Also, lamotrigine, which is Lamictal. So here's a generic lamotrigine and bottle, and over here are the brand name tablets, Lamictal. You see they have a different kind of shape, and they're each a different color. And then this is a label, and you see here an example of tall man lettering, Lamictal. For the adverse effects or side effects, most of these drugs can produce sedation, nausea, and lack of coordination. So they all produce sedation, nausea, and ataxia. Lithium can cause increased urination, dry mouth, difficulty concentrating, as well as tremors. And long-term use can result in kidney toxicity, as well as elevated white blood cell count, a goiter, hypothyroidism, weakness, and drowsiness. Now, I talked about lithium toxicity on a previous slide. It's important to note the signs and symptoms of a lithium overdose. That includes diarrhea, dizziness, nausea, stomach pains, vomiting, and weakness. The patient should be instructed to call their physician if the signs of toxicity occur. Now, a special note with Lithobid, Lithobid tablets need to be discarded after 6 months. So they shouldn't have an extended, what we call a beyond use date, or the expiration date that we put on the label for the patient when they take them home. These need to have an expiration date of 6 months. They actually could become toxic. They're and definitely ineffective after 6 months. So we want to highlight that expiration date so the patient doesn't keep them hanging around. The warning labels used to treat for drugs used to treat bipolar may cause dizziness or drowsiness or may impair their ability to drive. They should avoid alcohol. They need to drink lots of water. Again, water, partly because of the kidneys, especially with lithium, but water, not carbonated beverages with the anti-seizure medications used to treat bipolar. They can take it with food, drink, swallow whole, do not crush or chew. There is kind of an exception with that. Tegretol actually has a chewable tablet, so it's meant to be chewed. Avoid pregnancy. Again, these drugs to treat bipolar disorder are generally category D pregnancy risk, and they should not discontinue without the being followed by the physician. Sound alike, look alike. Lithium carbonate immediate release and lithium carbonate extended release. And then Depakote and Depakine. And I'm going to throw in there Depakon. Now, we also use some antidepressants and, we use antipsychotics and an antipsychotic antidepressant mix. So fluoxetine is antidepressant and olanzapine is an antipsychotic. That brand name combination drug is known as Symbyax. And there's some bottles here that show you the labels for the Symbyax. Now with a combination drug, this is kind of the first time we've talked about them, both strengths have to be listed. So each of the ingredients, so it comes 325. The olanzapine is the first drug, so it's actually 3 milligrams of olanzapine with 25 milligrams of fluoxetine. And then 625, 650, 1225, 1250, so that you can identify those tablets. And then we use the antipsychotic drug aripiprazole, which is Abilify. And Abilify comes in tablet form, and I have a photo there for you to see the different colors and shapes of Abilify. Okay, that is chapter 6, treatment of depression. Now it's time for questions.